speaking of passionate, I get the honor of introducing our next speaker, who is, I might have introduced her once or twice before, I think, over the years. I think I tell her I have the personal record for, I think, most introductions of her, but I can, which is wonderful, because I can never say enough great things about the Mental Health Commissioner, Dr. Ann Sullivan. Dr. Sullivan has a vast knowledge of our field, but more so, she is such a wonderful collaborator, and this is why this event today, as I said in the beginning, there are so many parts where we can be working together so successfully, and I think that with her leadership and you know, in Commissioner Neifeld's leadership, I think we're going to see some real collaborative efforts moving forward here. So we're very excited about it. So Commissioner Sullivan, if you'd like to come up and speak, thank you.
Hi, good morning, everyone. That's a hard act to follow, Dr. Margot. And I do want to say you set the stage for a lot of what I'm going to be talking about, and I really appreciate your comments, because I think they're very wise. I came in towards the end, so you didn't hear the whole thing, but definitely the last ones which pertain. First of all, it's a real pleasure to be here. I want to thank Mike Alvaro and Glenn Liebman and Harvey Rosenthal for inviting me today to be here. I think this is a critically important summit where we begin to get together and talk about really treating the whole person when someone comes to us. And I think that you'll hear from me, and later you're going to hear from Commissioner Neifeld, and I think you're going to hear that we're both on the same page with this, and that we've already begun to look at a number of initiatives, but also to take very seriously, for example, the comments that you had earlier, Dr. Margolis, about respite beds and what might be needed in the system, and to look at what those models might be going forward. But before going into that, I just wanted to thank you all for what you do each and every day. I think that since this pandemic, all of our systems of care have been so stressed, but everyone here in this room continues to do all the hard work of serving the individuals who need that help in New York State. So on behalf of myself and the Governor, I want to thank you. I want to thank you for what you do each and every day. And our job, my job, is to try to make what you do easier and better. So I think that's what this dialogue is about. How do we work together to provide even better services to all the people that we serve? And so I'm going to talk a little bit about what we're thinking of. It's certainly not as comprehensive a plan as we would want, and we'd like feedback. And I also want to congratulate the association on their Crossroads document, which I think very clearly outlines the issues and some great suggestions about what to do about the problems. So let me just talk a little bit about this collaboration, this concept of integrated care, the whole person. I think, as you hear and as you know, our systems have been unfortunately siloed in ways which we do a lot of good work in those silos, I'm not saying we don't, but when it comes to complex individuals who have both problems, we haven't been as good at providing the services that individuals need. And I think we have to work together to do that. I think it's two things. I think it's somewhat the silos that our systems have built. I also think it's the education of our staff and our providers to understand the cross issues that happen. And I don't think we've done as good a job often in terms of training. And that's why sometimes people close doors because they kind of don't know what to do. And other times it's our regulations and the way we're designed and the way we pay for things that can be obstacles. So there's many pieces, I think, that have to come together if we're going to fix it. And I think that we have some ideas, and it's going to take some work. And we certainly need your ideas and your assistance in how to do this. So I just wanted to talk about a couple of things. First of all, that we've been doing in there was just a meeting yesterday with the three commissioners, that's NYS OMH and OPWDD, and the county mental health hygiene directors, and that's going to be something called the Interoperating Coordinating Council. It's got a fancy name. But what it will do is actually bring together for an ongoing dialogue and ongoing discussion of how to fix things. Let me just put it that way, how to fix things. So that began yesterday, and that's going to continue, and there are already some good ideas. Then there's the summit today, and I think that that's an ongoing partnership of community-based providers and the leadership in the state to try to do these services better. I also want to talk about a couple of initiatives that we've started, just so you know that we're really committed to this. About a year and a half ago, we established a dual diagnosis treatment unit for adults at Kings County Hospital in New York City. And that was something which was done, that crossed over regulations, that was financed better than some units are financed, because we knew that they would need additional staff. And also a step-down unit associated with that, which was run by OPWDD, so that individuals who couldn't leave that unit and go home had the time to be in a residential program anywhere from 3 to 6 to maybe 9 months to get ready to go home. And while it hasn't solved all the problems of adult individuals with dual diagnosis in New York City, it's been very, very helpful. And the other thing we're doing there is establishing a consultation center, which soon will become broader across the state. We have, part of it was gathering together the expertise of individuals who knew how to work the very best with individuals with dual diagnosis. And so now we have that core group of staff, and we're going to be expanding that in terms of a learning environment and a learning collaborative working with OPWDD, so that that expertise can be spread across the state in terms of having availability of consultation, etc. That's not all up yet, but that's something that we're going to be working on. The second center of similar to that is one that will be opening in, I think it's the fall of next year, fingers crossed, in upstate New York, in SUNY upstate, for youth. And that's going to be a specialized dual diagnosis unit for youth who have both developmental disabilities and mental health issues, connected with a clinic system and a step-down system for youth. And that will also be available. I mean, so far it's only 2 things across the state. If these work, we will be expanding these in other parts of the state, and will be available again. SUNY has working with us to make sure that that unit also becomes a consultation, an availability consultation center to do work. Now the other big thing, which Dr. Margolis got started to talk about, is across the state, you know, we're developing a crisis system. And the crisis system of mental health involves 988, the number you call, and I hope you've all seen the advertisements for 988. And it also involves mobile crisis units, which is individuals leaving, individuals in the community, a team that can come and assess. And then it involves crisis stabilization centers, which are there for anybody to walk in or or family to bring, etc. if you're in a crisis. What we're trying to do, and it's a big lift, is make all of those services no wrong door. So that anyone who comes in, whether they have a drug use problem, whether they have a mental health problem, whether they are individuals with developmental disabilities, that they can be served in those settings. So what does that mean? That we're upping the training for our call center for 988, so that they know the services, what's available, and that they are also trained to be able to provide some counseling to a family member who might call, or someone with a developmental disability who calls. 988 is a counseling line. So basically, the average length of time somebody spends on 988 is 20 minutes. It's not like you just say hi and you get a quick, you can talk, and you can talk longer, or it can be shorter. But 988 is really there, and we want to make sure that we have that line also available for individuals with developmental disabilities. So we're doing training that's getting up, we're not right up to speed yet, but it will. Similarly, our mobile crisis services have traditionally not been well trained. There's a great pilot in Erie County and Wyoming County that was done by the county, and they did a wonderful job, and we're looking at that in terms of integrating the training so that that mobile crisis team in those 2 counties can respond to both individuals with developmental disabilities and with mental health problems. And so we're going to be looking at that model, and then we're going to be training our other mobile crisis teams across the state. It will take a little time to push that out. And similarly, with the crisis stabilization centers, now they're not up yet, so this is good, because this means that our training for those individuals, as we open those centers, they'll probably open the first one, well, some are open now because they have been grandfathered in, but the newer ones, probably within 6 months to a year, there's going to be extensive training on substance use, mental health, and developmental disabilities. And we'll be coordinating those stabilization centers with the service system. So we're really kind of working on this. Now, it's not going to be without its kinks. This is a very different cultural approach for our centers, and we have to get people well-trained, and they have to really know the service systems of all these groups of how to connect. But we're really working very hard on this. There's another point which we haven't got the model yet, but I think Commissioner Neifeld mentioned. This is looking at the issue of short-term beds for individuals who are dually diagnosed, whatever you want to call them. We call them crisis respite beds on the mental health side. I know there's a crisis respite system in OPWDD, but it's really not often for the youth who's in really acute crisis, and sometimes they have trouble getting into those beds. So we're looking at, and we haven't finished it yet, a design for piloting some beds that would do what you had mentioned, Dr. Margolis, have that availability for someone when they're in an acute crisis and they have this dual diagnosis, to have a place to go if they need to. And it would be a transitional beds. So we're looking at that. The other thing, which will open soon, we have a model in mental health called home-based crisis intervention. And home-based crisis intervention, this is actually state-funded programs, so it's not yet reimbursed by Medicaid. We have about 3,600 families in mental health in this program. And the home-based crisis intervention is a team that goes into the home and will work with only its caseload, maybe 3 families. And that team can work with that families intensively for, they often work with them for 6 to 8 weeks, 10 weeks, the longer if necessary, often to prevent hospitalization, but also post-hospitalization, and to help the family in vivo really learn how to follow some of the practices that can help them work with their youth. 2 of those teams are going to be soon, there's going to be an RFP going out to establish 2 of these teams that will focus on individuals with dual diagnosis. And those teams will be trained, co-trained by OPWDD and OMH, and in those teams, as a pilot, we will see if that works, and that's something that we will again expand. We've never done that before. We've never kind of really integrated, because certainly working with some families with youth with developmental disabilities, you really need a different level of skill set than we traditionally have in mental health, so we really have to get people well trained to do this. But this should be happening soon.
Just a point of clarification, you used the term dual diagnosis a few times. You're referring to IDD and MH?
Yes.
Okay.
Yes. Yeah. I'm sorry. Yeah. So this is focused. These 2 teams will be focused on MH and IDD. That's their main focus. We're doing a lot of integration on the substance use side too, but everything I've been talking about has really been between the 2 agencies. So I think this is a very exciting model, because when we think about some of the youth who kind of in emergency rooms, I think you probably need 2 things. You probably need what Dr. Margolis was talking about, which is a respite situation for youth who can't go home. But then for a lot of them, I think if you had a team that met them in the ED and the next morning was there to work with the family, you could avoid even the respite. You could avoid those things. So we're working on this to see if this is a model that might work. Well, it's always interesting whether something's funded by Medicaid or not, but one of the good things when it's not is the flexibility is incredible. So those teams can do whatever they feel that's needed. So it gives us a chance to really understand what the model will be, but before being constrained by what sometimes are your funding streams. So this is very exciting. We're going to be working on that, and we're really looking forward to moving it along. And then the other was what I mentioned earlier, just to mention briefly, the whole issue of training. And I think that this is something that we have not paid attention to in the way we need to. And I think some of you are probably well familiar with the ECHO model, where you basically do a combination of, it's virtual, but it's virtual, it's not online learning, it's virtual with case conferencing and people presenting cases, and also a didactic piece. It's worked very well in working with individuals, elderly, and especially individuals in nursing homes. One of the first ECHO project was working with multiple nursing homes many nursing homes across New York State, in terms of integrating mental health services into those nursing homes. So it works well when you're trying to integrate things. And that's something that we are in the process with Commissioner Neifeld of designing now, and we have money for this, and this will probably become live next year as well. And what topics we will use, the focus, etc., is something that we will be deciding jointly. But I think it's a way to spread, it's using technology to spread the training in a very useful way that I think can be very effective. And it really gets down to the level of case conferencing and stuff. It's not just a didactic presentation, it helps people learn how to do things. So those are some of the ways we're going, from the intensive services particularly, and then also to the crisis services. And then the last thing, which we haven't done too much on, but I think we have to begin to think about, is our clinic systems, and where those clinic systems need to have this overlap. You know, what's fascinating is that many providers of clinic services for the developmentally disabled and mental health are the same provider. They are under the umbrella of the same organization. But partly it's been our regulations, the way we fund things, the way we require things that have helped keep those silos and keep things separately. But the good thing about that is that that means that there's a number of our clinic providers who have expertise in both. And if we can kind of pull that together and help them learn better how to work in the clinic system and how to train, I think that that's a kind of strength that we haven't utilized as well. So that's the next phase that we will be, and we need a lot of advice from you guys on that too, as to how to do that, so that we have